Hi everybody, and welcome to our module on muscular dystrophy. The muscular dystrophies are a group of genetic disorders. There are more than 30 different types that have been described. They all result from defects in genes that code for proteins important for muscle function, and therefore the main symptom of all of these disorders is progressive muscle weakness. Most of the muscular dystrophies are very rare. I've listed on this slide the 3 variants of muscular dystrophy that you should know for the USMLE Step 1 exam. The first one is Duchenne muscular dystrophy. This is the most common variant. The second one is Becker muscular dystrophy. This is a milder version of Duchenne, but it shares many genetic features with Duchenne, and for that reason these two are often discussed together. And then the third one is a rare type of muscular dystrophy called myotonic muscular dystrophy, but the reason you should know this one for the Step 1 exam is because it is an example of a trinucleotide repeat disorder, and I won't discuss it in this video, but I do discuss it in detail in the video on trinucleotide repeat disorders. So like I said before, Duchenne and Becker muscular dystrophy are often discussed together. One of the reasons for this is that they're both X-linked. In fact, they're often called the X-linked muscular dystrophies. In addition, they both involve a gene called the DMD gene, and they both involve a protein called the dystrophin protein. And you shouldn't confuse either of these muscular dystrophies with myotonic dystrophy. That disorder has a different gene, a different protein, and it is not X-linked, it is autosomal dominant. So we'll start by talking about Duchenne muscular dystrophy, which is the most common form of muscular dystrophy. It's an X-linked recessive disorder, and it has all the usual features of X-linked recessive disorders that I discussed in the video on pedigree, so all male carriers are affected. A third of cases are due to new mutations in the fertilized egg. In other words, there is no parental carrier that passes on a mutated X gene. In 2/3 of cases, the X gene that is abnormal in the son is inherited from a carrier mother. The gene that is abnormal in Duchenne muscular dystrophy is the DMD gene. DMD stands for Duchenne muscular dystrophy. And this gene is famous for its massive size. It's 2,300 kilobases in size. It takes up 1.5% of the X chromosome. It is among the largest known genes. And because it is so large, there are lots and lots of nucleotides that have to be replicated to copy this gene, and therefore there is a high chance that a mutation will occur. And this gene codes for a protein called dystrophin, and that's what's abnormal in Duchenne muscular dystrophy. Dystrophin is a protein that's important for maintaining muscle membranes. It connects intracellular actin proteins to transmembrane proteins. Specifically, it connects actin to proteins called alpha and beta dystroglycan in the membrane, and these two proteins in turn are connected to the extracellular matrix to a protein called laminin. So in this way, dystrophin plays a role in linking actin inside the muscle cell to proteins in the membrane and outside the cell. And I've drawn a picture of this at the bottom of the screen to help you understand better. We have actin protein, which is connected via dystrophin to dystroglycan in the cell membrane, and in turn alpha and beta dystroglycan are connected to extracellular matrix proteins like laminin. Dystrophin is important in skeletal muscle, and that results in many of the muscle symptoms of muscular dystrophy. However, it's also found in cardiac and smooth muscle and also in some brain neurons. And as we will see, the fact that it's found in cardiac muscle is important because many patients with muscular dystrophy develop heart failure and cardiac complications. One of the most important things for you to understand for the Step 1 exam is what I've listed on this slide about the dystrophin gene mutations related to Duchenne and Becker muscular dystrophy. Most of the mutations in both of these disorders are deletions. However, in Duchenne muscular dystrophy, the deletion results in a frame shift mutation. In Becker muscular dystrophy, the deletion results in a non-frame shift mutation. I discuss frame shift mutations in detail in the video on DNA mutations, but by way of brief review, in Duchenne muscular dystrophy, the frame shift mutation results in a disruption of the reading frame. This leads to encountering an early stop codon, and thus children born with Duchenne muscular dystrophy have a truncated or absent dystrophin protein in their bodies. In contrast, children born with Becker muscular dystrophy have a non-frame shift mutation. Thus, they typically have some functioning protein, and therefore this tends to be a less severe disorder. So even though both disorders involve deletions of the same gene, what distinguishes them and why one form is more severe than the other has to do with whether or not the deletion is a frame shift mutation. Just to make this very clear, let's look at the drawing I've made on this slide. Under normal circumstances, the dystrophin gene has a series of codons that I've numbered 1, 2, 3, 4, and 5, and these lead to synthesis of a normal dystrophin protein. In a child born with Duchenne muscular dystrophy, the dystrophin gene has a deletion that occurs after codon 2, and in this case it is a frame shift mutation, and therefore none of the normal codons after codon 2 are encountered. This leads to either no synthesis of dystrophin protein or a very truncated protein. In contrast, in children with Becker mutation, the dystrophin gene has a non-frame shift mutation. In this example, I've shown a mutation that leads to loss of codon 3. Thus, what you get is an abnormal protein that's missing some of the amino acids, but it still has many of them intact because the mutation did not shift the reading frame. Therefore, Becker tends to be a less severe disorder, even though it involves the same gene and the same protein. When there is loss of dystrophin protein, this leads to myonecrosis. This means that enzymes found inside of muscles can spill into the blood and be detected by blood test. So creatine kinase elevation in the blood is common in the early stages of Duchenne muscular dystrophy. It's released from diseased muscle. Other muscle enzymes can also be elevated in the blood, including aldolase, AST, and ALT. When children initially present with this disorder, the proximal muscles are typically affected first before the distal limb muscles. In addition, the lower limbs are affected before the upper extremities. This means that affected children will have difficulties with activities that involve the lower extremities, things like running, jumping, and climbing stairs. A classic sign of Duchenne muscular dystrophy is when children use their hands to push themselves up from a chair because their lower extremities are so weak. This is called Gower's sign. In addition, they are classically described as having a waddling gait. Basically, they are using the lower parts of their legs to waddle because the upper parts of their legs have become weak. And then finally, the muscle eventually becomes replaced with fat and connective tissue, and this can result in apparent enlargement of the calf. This is called pseudohypertrophy. Many children with Duchenne muscular dystrophy eventually develop a cardiomyopathy. That's why I take care of a few children with this problem. They will develop a depressed left ventricular ejection fraction and systolic heart failure, and they can have myocardial fibrosis seen on biopsy. They can also develop conduction abnormalities, including AV block and arrhythmias. The classic finding on a muscle biopsy, which is rarely done in the modern era, is degeneration of muscle fibers and replacement of muscle by fat and connective tissue. This is an example of what a biopsy slide can look like here. The muscle fibers have been replaced with these clear spaces, and that represents fat. A Western blot test used to be done for diagnosis, but this has been replaced by genetic testing. I talk about Western blot in the video on blotting, but it is a technique that's used to detect proteins. In a Western blot in a patient who has Duchenne muscular dystrophy, there's usually absence of the dystrophin protein. In a patient who has Becker, there's usually an altered dystrophin protein. So if you look at this picture on the right side of the screen, a normal patient is in the middle, and that patient has a band about this far down the gel. A patient with Becker muscular dystrophy also has a band on the gel, but it's at a different location, and that's because the protein has been altered by a non-frame shift mutation. In the patient with Duchenne muscular dystrophy, there's no functioning dystrophin protein, and therefore there's no band seen on the gel. In the modern era, the diagnosis is usually made with genetic testing, usually with variations of the polymerase chain reaction test. This test can identify the most common Duchenne muscular dystrophy gene abnormalities. Basically, it turns out that most children with this disorder have one of a small number of typical deletions, so PCR can be used to test for those deletions, and if one of them is found, then the diagnosis is made. I'll finish by talking about Becker muscular dystrophy. It is also an X-linked recessive disorder, just like Duchenne. In Becker muscular dystrophy, 90% of cases are inherited from carrier mothers. The reason for this is because this is a less severe disease, so more males live to pass on the gene to female offspring, and thus there are more female carriers of this abnormality. In terms of symptoms, this is basically a milder form of muscular dystrophy. It has a later age of onset. Usually children are older. Some patients remain ambulatory during their entire lives, and patients often survive into their 30s or beyond with Becker muscular dystrophy. And that concludes our video on muscular dystrophy.